morning to the third episode of the JCMC interview series. I am Michele Introna, social media editor of the Journal of Clinical Monitoring and Computing. And here with us today we have Denise Battaglini. Is a physician, anesthesiologist, and intensive care physician at Ospedale San Martino in Genova, Italy. So welcome, Denise.
Thank you, Michele. Welcome.
First of all, for this episode, I would like to start remembering Professor Pelosi, who passed away a few weeks ago. It was really a pain for Denise group, from which the professor came, but for the community, the international community of ICU and anesthesia. So I would like to thank Professor Pelosi for everything he did for and his commitment for our profession.
Thank you, Michele. Yes, he was our great mentor and always inspired us. He had an innovative view, and I can see that his suggestions were essential for all our papers and also for this paper we are talking about.
Today we are here to discuss about a paper that Dr. Battaglini published in the Journal of Clinical Monitoring and Computing a few weeks ago, which is effects of positive end-expiratory pressure on brain oxygenation, systemic oxygen cascade, and metabolism in acute brain injured patients, a pilot physiological cross-sectional study. So I would like to start with a simple question with you, Denise, which is if you can tell us in brief what the study is about.
Yes. So this was a pilot physiological cross-sectional observational study, which was conducted in patients with acute brain injury in 2021. The primary aim of this study was to evaluate the effect of a PEEP augmentation test, meaning from 5 to 15 centimeters of water of increase on brain oxygenation evaluated through near-infrared spectroscopy, as well as on systemic oxygen cascade and metabolism, which were assessed through the arterial and venous blood gas and through the use of indirect calorimetry. Indeed, indirect calorimetry can estimate the type and the amount of the substrates oxidized and the energy produced by measuring the pulmonary gas exchange. And the secondary aims include to determine if the changes in the regional cerebral oxygenation are correlated with the changes in the oxygenation cascade and metabolism, and also correlation with the mechanical ventilation setting in these patients.
Okay, thank you. Very clear. I would like to ask you, I mean, you said you started to enroll patients in 21, right? So so you were quite fast if you consider the normal timing and the normal problems you could encounter doing studies. So you were really fast. You come from a very productive group. So I would like to ask you what kind of journey happened from the generation of the idea to the publication, and if you encountered some challenges, and what were the challenges you encountered doing this study?
Yes, first of all, as you can see, is a pilot study. So it was a very fast recruitment because we included only 10 patients in this pilot study. And behind the recruitment, we needed to find a patient who needed a PEEP test for the optimization for the clinical reasons, like optimization of hypoxemia or some desaturation, to optimize the brain and the lung setting of mechanical ventilation. And this was the major challenge to put all the monitoring systems. So this is the reason why we included only 10 patients, and this was a pilot study. But the idea of this paper come from some experimental studies of many years ago, in which they use the indirect calorimetry to better investigate the relationship between the systemic oxygenation and the metabolism and the cerebral oxygenation. In that case, they use the invasive monitoring tools for the oxygenation of the brain, like the PbTO2. And but I think the main strength of this study is that is the first in humans, despite being of a small sample size, which can report insights about the oxygen cascade and the metabolism from the brain to the systemic compartment. And another idea behind the study was that the setting of mechanical ventilation, and in particular of PEEP in patients with acute brain injury, is yet to be defined. We don't have a clear recommendation to set the PEEP in this category of patient. And so we know that the best PEEP setting in this patient is a major challenge. So an optimal PEEP setting, generally speaking, is the one which allow an appropriate gas exchange, keep the lung open, preventing the collapse, but also preventing the overdistension, and is a PEEP that not affect the hemodynamics, but also in this category we can add that the optimal PEEP should also provide an optimal brain oxygenation. So for this reason,
sorry if I interrupt, but now another question comes out in my mind. So what were the main outcome, the results of this study? I mean, so can you provide us an insight on what is if the PEEP influenced the brain metabolism? Because this is a really clinical question. I mean, I am a neuroanesthesiologist, and this is something we always struggle with the surgeons, for example, during the OR, but also later on during the ICU stay after surgery, because sometimes you would like, as an anesthesiologist, as intensive care physician, to increase PEEP for clinical reasons, but you have to, it's the only case where increasing PEEP not only has detrimental effects on hemodynamics, but also you are taught in the university or during residency that PEEP is very harmful for the brain. This is the common sense, but is it true? So does it affect cerebral metabolism, and what clinical outcome could we expect?
Yes, from the physiological point of view, I would say that an increase of PEEP usually increase the intrathoracic pressure and limit, in some cases, the venous return, does influence the cardiac output, which decrease. And the cardiac output is one of the key parameters influencing the oxygen delivery and potentially impairing the systemic and cerebral hemodynamics. However, I can see that in some cases, for example, increases in blood pressure or heart rate or stable hemodynamics, according to the Frank-Starling relationship, you can see that the venous return and the cardiac output can be stable after the increase of the intrathoracic pressure. So also this can be determined, for example, by changes in the pleural pressure, but for example, in our study, we did not partition the mechanics, so we don't know. And also the increase of the PEEP can cause the compression of the pulmonary capillaries and increase the right ventricle afterload, and thus reducing the cardiac output. So all these mechanisms, we wanted to investigate all the oxygen cascade for this reason. So from the brain oxygenation to the delivery of oxygen to the production of the carbon dioxide and the oxygen consumption, so including also the hemodynamic changes. And this study, I believe, is something important from the physiological point of view, despite being, as I told before, told you before, about only 10 patients. But it was useful to understand the changes in the oxygen cascade in patients with brain injury upon the application of 5 to 15 centimeter of water of PEEP, with an increase of 2 centimeter of water every minute. And we found that in this category of patients, which were patients with stable ECP and stable cerebral perfusion pressure, stable parameters, the application of PEEP up to 15 is safe and does not affect the systemic hemodynamic and the regional oxygenation and metabolism. Also, we found that the regional brain oxygenation measured with the near-infrared spectroscopy has a good correlation with some systemic parameters, and these are the oxygen delivery, the DO2, the arterial saturation of oxygen, and the production of carbon dioxide, which was measured by the indirect calorimetry. So this is interesting because since the higher production of the carbon dioxide, for example, can lead to a higher cerebral blood flow because of the vasodilatation, and in turn, this can result in more oxygen to the brain and improve the overall brain function. But we did not find an improvement in cerebral oxygenation, just a stable situation. I believe this study can suggest that the cerebral monitoring, the monitoring of the cerebral oxygenation could be used to individualize the PEEP and the mechanical ventilation setting in patients with a stable ECP, intracranial pressure. But also maybe we can use, if we don't have the near-infrared spectroscopy or a monitoring of oxygenation, maybe we can use the delivery of oxygen as a systemic parameter.
Okay, thank you. Very, very clear and very interesting. I found this study really elegant in its conduction. So coming back a little bit to the first questions. So did you encounter some challenges along your pathway? I like this question for the podcast and this interview series, because when we read the literature as readers, we always think that the other ones are better than us, and they do not have the problems we have as researchers. So everything seems perfect because it's a whole picture from the end. But maybe as a researcher you encounter some challenges, or I would like to humanize more the research process. I don't know, you know what I mean.
Yes, I can confirm it was a challenge. First of all, to find the patient who needed a PEEP test for clinical reasons, and to have all the monitoring tools available at that moment to measure during the process of testing the PEEP. And this was a major challenge, to maintain the observational nature of the study and not interventional. So this is the reason why we included very few patients, because we had difficulties in finding patients who can benefit of about this maneuver. Other challenges are limitation due, for example, to availability of calorimetry monitoring that, for example, was available in our unit just for a few months, and we needed to include all the patients during that month. So we had a permission to use it, but was just for a few period of time. And then there are some limitations about the study in general, since first of all, that the data were collected as spot values because of time and possibility to perform more than one measure, a repetitive measure. So this is a major flaw. And other points is that we selected patient with optimal fluid resuscitative status, patient with an optimal ICP, but patient who needed, for example, to adjust the mechanical ventilation. So maybe we have not seen some great changes in the oxygen parameters because of that, because the patients were stable and did not have, for example, heart disease or problems. And other challenges can be the interpretation of the NIRS. The near-infrared spectroscopy is, of course, a non-invasive method of monitoring and can be influenced by a lot of things like light, tissue, blood volume, saturation, and so on. So careful to interpret the data.
Yeah, I mean, I think I mean, this is really interesting in the sense that it tells us that we have to monitor what we are doing always. We are a journal of monitoring, and intensive care is basically the specialty of monitoring physiology. So whenever you are changing and you are unbalancing physiology of a patient for doing something you need in that moment, you have always to monitor the end of the process. So in this case is the near infrared spectroscopy, but it's something that could be applied to basically every organ. So this is why I really found interesting the study, because it's like studying, it's like the butterfly effect. You move from one end of the body, you go to the other one, and you want to monitor at the starting point, during the process, and at the end of the process. So it's really interesting.
Yes, I believe from the physiological point of view was really interesting to see the changes and so on. But from the clinical point of view, the main message should be that we need to monitor what we are doing. If we change the PEEP, if we change the mechanical ventilation setting, we always need to monitor what is happening. And in this case, we have a brain injured patient, what is happening to the brain as well as to the lung, using always a lung protection ventilation strategy. I believe it's not simple to reproduce the entire study, because we had a lot of monitoring tools, and usually maybe we don't put calorimetry as well as NIRS, as well as all this kind of monitoring. But from the physiological point of view, this study gave us some important insights.
Thank you, Denise. It was really interesting to talk to you and about your study. I think we are done with the interview. So before saying hello to everybody, I would like to invite you all to follow the page on Spotify, the JCMC on Spotify, on the Amazon Music, on YouTube, and to follow us on Twitter, to interact with us on the social media, because it's important for us to produce quality contents and to continue producing contents for the public. So thank you, Denise.
Thank you for the invitation. Bye-bye.
Ciao, it was really nice, and see you next time.